Last time we talked about, remember, immune hemolytic anemia. So last time we spoke about immune hemolytic anemia, that I told you that we divide under the when we classify hemolytic anemia, I told you intracorpuscular defect and extracorpuscular defect. Then under the intracorpuscular defect, I told you that we divide into acquired and familial. Familial, hereditary or acquired. Under hereditary, we talk about enzymes defect, membrane defect, and the hemoglobinopathies, right? And under the acquired, we talk about the paroxysmal nocturnal hemoglobinuria. So coming to the extracorpuscular defect, we have divided again into hereditary and acquired. Under hereditary, I told you, is about familial HUS, and the most important is acquired causes. Under those, we divide into the immune hemolytic anemia and the non-immune hemolytic anemia. So last time, just to recap a bit about last time, so under immune hemolytic anemia, we divided again into, it consists of two types. One is autoimmune hemolytic anemia and another one is the alloimmune hemolytic anemia. So autoimmune hemolytic anemia by itself, it means that it is caused by the increased RBC destruction due to the presence of autoantibodies against the RBC. Okay? Means you're producing antibodies against your own cell. And alloimmune hemolytic anemia, it is caused by the antibodies against the non-self RBCs. And it usually occurred following an unmatched blood transfusion and also in hemolytic diseases in the newborn. Okay? So autoimmune hemolytic anemia, I told you that basically we classified already autoimmune hemolytic anemia, you know that it results from an increased RBC destruction due to the autoantibodies against the RBC. So here these autoantibodies, they said it can be of IgM or IgG. So again we classified IHA according to the optimum temperature at which the antibody is active. The optimum temperature at which the antibody is active is used to classify IHA. So, forget about the Coombs test. So, the classification we classified into the warm IHA, okay, warm autoimmune hemolytic anemias, which means that warm antibodies binds at 37 degrees Celsius. And it is the most common type of autoimmune hemolytic anemia. It comprises of 80%. And here the autoantibodies are IgG and are directed against the multiple RBC antigens. And also, it has got a high risk of thromboembolic complications, we have seen. And here the direct Coombs test is positive. So, under the causes of warm IHA, it can be primary or secondary causes. Primary, idiopathic, unknown, but secondary, which comprises of 50 to 60%. Under this, we have an autoimmune disease like SLE. Then we have lymphoproliferative diseases like chronic CLL, lymphomas. Then we have certain infections, immunodeficiency, and certain drugs like penicillin, methyl-dopa, and quinidine. So then again we have IHA can be classified actually according to the temperature at which the antibodies is active. We have cold, warm and cold. Cold IHA, again we subdivide, it can be cold agglutinin disease or a cold hemolysin disease. This cold hemolysin disease is also called as PCH, paroxysmal cold hemoglobinuria. Don't mistake this with the paroxysmal nocturnal hemoglobinuria, okay? So under the cold agglutinin disease, this here what happened, it is a form of IHA in which here the antibodies is IgM and here it causes complement mediated hemolysis and RBC agglutination upon cold exposure at a low temperature 4 degrees Celsius. And here the direct Coombs test is positive for complement. So the causes can be primary and secondary. Secondary causes, we have certain infections like mycoplasma, pneumonia. Then we have viral infection like EBV virus. Then some autoimmune disease, lymphoma, Waldenström macroglobulinemia and myeloma. So now comes to the clinical manifestation of these IHA. Basically, like all they'll present you with hemolytic anemia. Hemolytic anemia, as I told you, they'll come with anemia, unconjugated hyperbilirubinemia. There'll be reticulocytosis, and there also will be increase in the LDH. So in this cat, that is the cold agglutinin disease, in addition to the hemolytic features, they will come with cold-induced symptoms. Like they'll come with acrocyanosis. On exposure to colds, they'll develop this acrocyanosis, livido reticularis, then Raynaud's phenomenon, and some cutaneous ulceration. And also venous thromboembolism. All autoimmune hemolytic anemia, as I told you, they have this venous thromboembolism. So comes to this paroxysmal cold hemoglobinuria. This is a type of IHA which is characterized by the donut-Landsteiner antibody. This is basically an autoantibody that binds to the RBC-P antigen in the cold and fixes the complement. However, upon warming, the antibody dissociates and complement lyses the RBC, leading to an intravascular hemolysis. Here the antibodies, we can't say like the warm and the cold that has got an IgG or IgM. But here the autoantibodies are polyclonal. So the causes that can cause this PCH is usually induced by infection. Remember, chronic syphilis is one of them, if you can remember that. And viral, and the other is immune dysregulation. However, it is very rare, affect usually the children, and they can come, as I told you, that they usually causes intravascular hemolysis. So these people will present it to your child with pain, abdomen, nausea, vomiting, and also the passage of a dark or red urine, which is a hallmark of PCH. And here the Coombs test will be, remember, for the cold, it will be positive for the complement, remember. So the treatment, and the treatment basically for warm IHA, we give blood transfusion, then folic acid supplementation, then we have the first line agent like steroids. We give at the dose of 1 to 2 mg per kg per day, and rituximab. This is an anti-CD20. Then if this first line doesn't work, we can always use the second immunosuppressive agent. Like among these, we can choose cyclophosphamide, azathioprine, cyclosporine or MMF. If instead of this the patient is still having, then we can go for splenectomy. And also, as you know that, I told you that the risk of venous thromboembolism is around 30%. So these patients requires to be given a prophylactic anticoagulants, like we can go for like low molecule heparin or heparin, conventional heparin. And obviously treatment of the underlying cause that causes this autoimmune destruction, the destruction. Then the treatment of cold IHA, as we know that cold can also, besides treatment of the hemolysis, we have to cold avoidance. So when we give blood for these patients, remember that we have to give a blood warmer, then steroids and rituximab. And for the PCH also, avoidance of cold, blood transfusion, steroids and hydration. Okay. So now we'll talk about the non-immune hemolytic anemia. So under the non-immune hemolytic anemia, as I told you, the extra corpuscular defect acquired, we divide into the immune and non-immune, because for better, although the classification I have given before, it's the same only, but I make it this way so that it's easier for you to know whether it falls under that or not. So under the non-immune hemolytic anemia, it can be due to endothelial damage or as a result of infection, or by some chemicals or drugs. Under the endothelial damage, we have the TMA. There is a thrombotic microangiopathy. Then it can be because of those mechanical prostatic bulb, or it can be due to thermal injury. And under the infection that can induces this non-immune hemolytic anemia, usually P. falciparum and Clostridium infection. And among the chemicals or drugs like dapsone and sulfasalazine, and among the chemicals, copper and arsenic are found to induce a hemolytic anemia. So we'll talk a bit one of them. So we'll talk about endothelial damage, that is a TMA. That is a thrombotic microangiopathy. So basically under this, so they say that this thrombotic microangiopathy, they are the clinical syndromes defined by the presence of three. There should be hemolytic anemia, then we have thrombocytopenia and organ damage. It is a clinical syndrome which is defined by the presence of these three triads: hemolytic anemia, thrombocytopenia and organ damage. And among the organ damage, what they found is that the kidney is the most common organ commonly affected, although any organs can be involved. So how it causes this thrombotic? Because as a result of endothelial injury, there is formation of the thrombosis in those capillaries as well as the arterioles. As a result of endothelial injury, there is formation of the thrombosis in the capillaries and the arterioles. Okay, again under this TMA, we include two things. One is the TTP and the other is HUS. Again, TMA include two diseases. One is the TTP and the other is HUS. So TTP is thrombotic thrombocytopenic purpura. So what is this basically? In this condition, they said that there is deficiency or there is mutation of this Adams 13 enzyme. In this TTP, they said it results from deficiency or mutation of this Adams 13 enzyme. What is the importance of this enzyme is that this enzyme, it cleaves the von Willebrand factor multimers into some small functional unit. However, deficiency of these enzymes results in the formation of larger units which will cross-link the platelets and increases the platelet aggregation. And because of this, they will result in the formation of some small microvascular thrombosis. Okay? So TTP is basically thrombotic thrombocytopenic purpura, and it is due to deficiency or mutation of this Adams 13 enzyme. The importance of this enzyme is that it cleaves this von Willebrand factor multimers into some small functional unit. So the deficiency of this enzyme, what happened will result in the formation of this multimer into larger units, and which will cross-link the platelets and increases the platelets aggregation. And because of this, they will result in microvascular thrombosis. So this TTP, they said it is characterized by a pentate. Pentate means fever, hemolytic anemia, thrombocytopenia, renal failure and focal neurological deficit. So this is a pentate or a pentat of TTP. So what are the causes of TTP? And again, it can be divided, it can be primary or secondary causes. So secondary of this usually from drugs, any HIV infection or malignancy. So the treatment, they said we have no other choice, we have to put them on steroids, then we can go for plasma exchange, or we can give rituximab, that is an anti-CD20, and aspirin because of the thrombosis. But they said that unfortunately the mortality is very high, 90%. So now coming to the HUS. So HUS, the full form is Hemolytic Uromic Syndrome. So what is this? So this, they are a part of the thrombotic microangiopathy. It is a clinical syndrome which is characterized by progressive renal failure that is associated with hemolytic anemia and thrombocytopenia. It is one of the most common causes of acute kidney injury in children, and the causes of this is usually infection with organisms producing Shiga-like toxins. And what are those organisms? They found that the E. coli, serotype 0157, H7 and Shigella dysentery. Okay? Are you clear with this? So the treatment basically is the same. we treat it with steroids. So all the treatment of thrombotic microangiopathy, we give steroids as the first line. Second line, you can go for these rituximab, then plasma exchange, and also supportive aspirin to be indicated. And if the patient has developed acute kidney injury, renal failure, then we can go for dialysis. So are you clear with this? Hello? Hello?
Yes, ma'am.
It's quite
Yes,
tough.
ma'am.
It's quite tough, I do understand. But we can't help it just to know a bit of it. At least if you know something even to classify and just know that yes, I've heard that TMA are basically thrombotic. TMA means what? Thrombotic microangiopathy. It is a clinical syndrome characterized by the presence of these three. Try it. One is hemolytic anemia, thrombocytopenia, and organ failure. And I told you most of the organ is the kidney. So again, it results from the endothelial damage, which result in the formation of those microvascular thrombosis. Okay, so it includes TTP and HUS. HUS is very common in children, and it is one of the leading cause of acute kidney injury in children. Okay, and it is usually caused by infection with these organisms that produces Shiga-like toxin. One is E. coli and the other Shigella dysentery. And TTP, basically it's also the same. It is the cause of this TTP. It's basically deficiency of these enzymes or mutation of that ADAMS 13 enzyme. That enzymes would happen, it is important to break that multimers into small functional unit. But deficiency of that enzymes results in the formation of the larger units, and that causes the formation of thrombosis because of platelet aggregations. So usually it presented with a pentate of, like there'll be fever, there'll be hemolytic anemia, there'll be thrombocytopenia, there'll be renal failure, and also they can present you with focal neurological deficit. So the treatment is basically steroids, rituximab, plasma exchange, and obviously aspirin, and in the cases of renal failure, hemodialysis or dialysis. So now comes to another important topic, which is DIC. That is, this is also falls us under the endothelial damage. Okay. So it falls because I will be talking on that endothelial damage. One is the TMA, second is the DIC. So other mechanical bulk, we don't need to talk. If there is a picture of that, suppose if a cardiology patient or a CTDS patient comes, send to us a call of hemolytic anemia, and knowing the history background that they have a prosthesis, so that can be the cause. Okay. So now DIC. Under DIC, it is also known as consumption coagulopathy. Okay. So what is DIC basically? It is disseminated intravascular coagulation. This is basically a clinical pathologic syndrome. A clinical pathologic syndrome characterized by widespread intravascular fibrin formation in response to excessive blood protease activity that overwhelms the natural anticoagulant mechanism. This definition we have no other way, we have to know. And the process of coagulation and fibrinolysis becomes abnormally activated within the vasculature, leading to this ongoing clotting and fibrinolysis, resulting in thrombosis as well as bleeding. So let me repeat, DIC is a clinico-pathologic syndrome characterized by widespread intravascular fibrin formation in response to excessive blood protease activity that overcomes the natural anticoagulant mechanism. The process of coagulation and fibrinolysis becomes abnormally activated within the vasculature, leading to ongoing clotting and fibrinolysis, resulting in thrombosis and bleeding. This is quite important because you might get a short note on this. So what are the causes of DIC? Because we see very common this disease. Number one is sepsis. Sepsis means any infection, okay? Be it a bacterial, be it a viral or anything. So sepsis basically is mostly bacterial only. Then obstetric complications like preeclampsia, then IUD, then those placenta previa or abruptio placenta. Then another cause is malignancy, mostly adenocarcinoma, and also acute myeloid leukemia, M3. Remember this. This is very common. We used to get as a, I mean, used to get as these questions, multiple choice question in PG. What are this thing they used to give you? And one of the causes of DICs is AML M3. Then trauma, then certain drugs like fibrinolytic agents, warfarin, then any intravascular hemolysis like acute hemolytic transfusion reaction, and also severe malaria. So these are the causes of DIC. Remember this: sepsis, obstetric complications, malignancy, then trauma, then drugs, then intravascular hemolysis as a result of severe malaria or acute hemolytic transfusion reaction. So what is the clinical? How will a patient of DIC present to you? They'll come with thrombosis, they'll come with bleeding and organ dysfunction. Okay? These are the three triad that DIC will present to you. So how to diagnostic evaluation? How to suspect that this patient will be having DIC? So DIC may be suspected in a patient who comes to you with generalized bleeding and unexplained thrombosis. So whenever you get a patient of unexplained thrombosis with generalized bleeding, you have to suspect DIC. So then what you have to do is that you have to go for the evaluation, send for the CBC, including the peripheral blood smear, go for the coagulation profile like PT, APTT, check the fibrinogen level and the D-dimer. So what you found here is that in the CBC you will have hemolytic pictures, right? You'll have thrombocytopenia, you'll have low fibrinogen, and there'll be elevated D-dimer. Although these are very sensitive, but for diagnosis, but remember that they're not that specific. So DIC is a clinical and a laboratory diagnosis based on the findings of coagulopathy and fibrinolysis in appropriate settings. Okay, so are you clear with this? So now comes to the treatment. Under the treatment, basically, as we know, what are the causes? So we have to treat the underlying cause. If you feel that sepsis is the cause, treat the sepsis. If you feel that malignancy is the cause, you have to treat the malignancy like AML. You have to treat that cancer, that AML. If you feel that it is a cause drugs or it's because of intravascular hemolysis like malaria, we have to treat the underlying cause. Then the second will come supportive. Supportive means hemodynamic stability. Then we have got blood transfusion for severe bleeding. Then platelet transfusion for severe thrombocytopenia resulting in bleeding. Then you can give vitamin K and FFP transfusion. Then, as we know that besides bleeding also they can cause thrombosis, so you can give heparin is indicated where thrombosis is life-threatening. Then remember there's another drug which we call tranexamic acid. This is, however, whenever we get a bleeding patient, the first and foremost that we doctor does is that we always give tranexamic. But remember that the tranexamic acid is contraindicated in DIC because it causes blocking of the fibrinolytic system and thereby increases the risk of thrombotic complications. So always try to evaluate the patient. So I told you that DIC always suspect in the presence of generalized bleeding in the setting of thrombosis, always think as DIC, and in the clinical context, like whether it is from obstetric or from sepsis or patient having severe malaria. So you always have to put that, am I dealing with a DIC?
Yes.
Yes, ma'am.
I think you all are feeling straightforward. Okay. So I think this ends the hemolytic anemia. The others you don't need to talk like the other classification that I've classified. Okay. So these I have already spoke here with regards to TMA, then DIC. These you just have to know: mechanical valves, thermal, this thing. Okay, so we'll move on to the next talk, which will be on pancytopenia. This is a very important long question. Okay, Just the introduction, pancytopenia. So the Habib will take another. This will take only 5 to 10 minutes. Then after that we'll be talking on the. So I think you're quite aware of the term pancytopenia, right? So what is pancytopenia? It refers to a decrease in all the peripheral blood lineages. That is, you'll get a combination of anemia, there'll be leukopenia, and there'll be thrombocytopenia. Okay? So all the three peripheral blood lineages will be decreased. So what is the mechanism of this? What is the mechanism of this pancytopenia? So basically it can be because of bone marrow aplasia, means the bone marrow doesn't produce by itself, okay? Or that is the mechanism, or it can be because of the bone marrow infiltrations by some, say, malignancy like leukemias, right? Or it can be because of ineffective erythropoiesis. Ineffective erythropoiesis, like, when we talk about the classification of anemia last time, then I tell you that the pathogenesis of anemia, it is because of two things. One is, it can be because of decrease in the RBC production, or it can be because of the increase in the RBC destruction. Under the decrease in the RBC production, it can be because of the maturation defect, which we call it ineffective erythropoiesis, right? Or it can be because of the hypoproliferative defect, means the bone marrow is not producing at all. So under the ineffective erythropoiesis also, they can cause us pancytopenia, and also because of the peripheral pooling or destruction. This is the mechanism of pancytopenia. It can be because of the bone marrow aplasia or infiltration. It can be because of the ineffective erythropoiesis that leads to this, or because of the peripheral pooling or destruction. So now comes to the causes. What are the causes of pancytopenia? So as we know that it can be because of the bone marrow cause itself, or it can be of the non-bone marrow. It is not necessary that the bone marrow itself can cause that. So under the bone marrow causes, we again say it can be because it can be a hypocellular bone marrow or a cellular marrow. Are you getting this? See, I'm just trying to put the classification so that it becomes easier for you. So under the bone marrow, it can be hypocellular or cellular marrow. Hypocellular marrow means very little cells in the marrow, and cellular means normal. Then coming to the hypocellular, what are the causes of hypocellular bone marrow? Usually aplastic anemia, one of the cause. Second one is hypocellular myelodysplastic syndrome or aleukemic leukemia. These are the three causes of hypocellular bone marrow. And under the cellular marrow means enough cells are there, but it's just that it has been infiltrated, like leukemia, then myelodysplastic syndrome, myelofibrosis, myelophthisis, then PNH and lymphoma. Okay, these are the causes of a cellular bone marrow. And the next one is the non-bone marrow causes. What are the non-bone marrow causes? Number one, we have any hypersplenism can cause pancytopenia. Then autoimmune disease like SLE, they can come with pancytopenia. Infection like TB, HIV, leishmaniasis. Then we have the vitamin B12 and folic acid deficiency. These causes ineffective erythropoiesis. And another one is a sepsis. Like those inflammatory markers can suppress the thing and they can come to you with pancytopenia. So let me repeat again about pancytopenia. See, pancytopenia is a long question. It's important. So what is pancytopenia? It refers to a decrease in all the peripheral blood lineages. There is a combination of anemia, leukopenia and thrombocytopenia. What is the mechanism? It can be because of the bone marrow aplasia or infiltrations, then ineffective erythropoiesis, and the third one is the peripheral pooling or destruction. So what are the causes? It can be divided into bone marrow cause and non-bone marrow cause. Again, under the bone marrow cause, we again divide it into, can be a hypocellular bone marrow or a cellular bone marrow. Under hypocellular bone marrow, we have aplastic anemia. Then we have hypocellular myelodysplastic syndrome and aleukemic leukemia. Under the cellular, we again have these following causes. One is leukemia, then myelodysplastic syndrome, myelofibrosis, myelothysis, PNH and lymphoma. So these are the causes. And coming to the non-bone marrow cause of pancytopenia includes number 1, hypersplenism, an autoimmune disease, SLE, infections like TB, HIV and leishmaniasis, and vitamin B12, folic acid deficiency and sepsis. Are you clear? So we'll be moving on to the disease condition called as aplastic anemia. I think I'll complete this. Time is still there, another 18 minutes. So I'll finish this in 10 minutes. The slide is not that long. Let me see. Okay. So what is aplastic anemia? What is the essential of diagnosis? Number 1, it is characterized by pancytopenia. There should be pancytopenia. Then no abnormal cells seen. Why we said this? Because if you get a leukemia and all, you can get the blast cells. But out here in the peripheral blood smear, you won't get any abnormal cell. Okay? And also the bone marrow is hypocellular. Like when we classified the causes, we said bone marrow and non-bone marrow cause. Under the bone marrow cause, we again further classified into hypocellular and cellular bone marrow. So what is aplastic anemia? It is a condition of bone marrow failure that arises from injury or abnormal expression of the hematopoietic stem cell. So aplastic anemia is a condition of the bone marrow failure that arises from the injury or abnormal expression of the hematopoietic stem cell. So the bone marrow here become hypoplastic. There is hypocellular and pancytopenia develop. Okay. So again we have to the classification. How to classify aplastic anemia? It can be constitutional and acquired. The classification, it can be constitutional and acquired. Under the constitutional, we have Fanconi's anemia, dyskeratosis congenita, and Schwarzman-Diamond syndrome. So this is the classification. And the acquired one, it is idiopathic. We don't know what is the underlying causes. Then chemotherapy can result in this bone marrow aplasia. Then radiotherapy. Then chemicals and toxins like benzene, toluene, insecticides. Then certain drugs that can cause this bone marrow aplasia like chloramphenicol, gold salt, sulfonizides, phenytoin and carbamazepine. These are anti-epileptic. Then certain viral infection like Epstein-Barr virus, parvovirus. These causes bone marrow aplasia resulting in aplastic anemia. Then it can be immune mediated also. And the last but not the least, pregnancy can also, but very rare. Okay. So these are the classifications. So when you talk about aplastic anemia, remember that it is a condition of a bone marrow failure. Means the bone marrow fails. And this is because it arises from the injury or abnormal expression of the hematopoietic stem cell. So the bone marrow becomes hypoplastic and pancytopenia develop. Classification, it can be constitutional or acquired. Under constitutional, it can be Fanconi's anemia, dyskeratosis congenita, and Schwarzman-Diamond syndrome. Under the acquired, those are the following causes. So with regards to this commuter criteria, please see there it is in Davidson. Okay, I forgot to paste that commuter's criteria of the aplastic anemia, very short. So now comes to the laboratory finding. So what the diagnosis, how to diagnose? Remember that the hallmark of aplastic anemia is pancytopenia. All the cell line should be low. And remember that anemia is associated with reticulopenia. Means the reticulocyte count is low, right? When we classified, remember anemia, I told you that anemia, you have to see the reticulocyte count. If there is reticulocytosis, it goes towards the hemolysis. But if the reticulocyte count is low, it goes towards a hypoproliferative anemia or a maturation defect. There is ineffective erythropoiesis. Then the RBC can be normal or sometimes macrocytic RBC can be seen, especially if the causes of this, sometimes you can get the macrocytic, they said. And the bone marrow, if you do aspiration and biopsy, it appears hypocellular. Very less cells are there, and there is no infiltrations, no abnormal cells seen, neither fibrosis, and the marrow space is composed mostly of fat cells and the marrow stroma. So the laboratory findings, you'll get pancytopenia, and also when you do a bone marrow, it's usually hypocellular marrow, no infiltrations or fibrosis. It's very clean, but less cells are there. So what will be the symptoms and the signs? So they'll come with the manifestation of pancytopenia, right? Anemia. So anemia, patient will come with the symptoms of anemia, like weakness, fatigue. Leukopenia, they causes vulnerability to bacterial or fungal infection. So these people will come with infection. There'll be high fever, anything, whether they come with pneumonia, they come with any infection, they can come with a subcutaneous infection, a skin infection, or anything. Because of the leukopenia, it causes vulnerability to bacterial as well as also the fungal infection here. Very important. Then, because of thrombocytopenia, they will come with mucosal and skin bleeding. Okay? So, on examination, they will have pallor, they'll have all those purpura and petechiae secondary to thrombocytopenia. And another important thing that you should know here, that the presence of hepatosplenomegaly, limb adenopathy or bony tenderness should not be present. Thus, their presence should lead to the question of diagnosis. If you get a patient of anemia or pancytopenia with hepatosplenomegaly and limb adenopathy, then this is not a plastic anemia. You have to question yourself and try to search what are the other causes. Clear? So, and now the treatment comes to the treatment. Basically, supportive we have to go, like we have to give them blood transfusion for the anemia, platelet transfusion for the thrombocytopenia, then hematopoietic growth factor for the leukopenia, like those GCSF, then treatment of the infection. Then now the main treatment is that they said in the young people we always ask for this hematopoietic stem cell transplantation. But however, if that is not feasible, then you can go with this immunosuppressive therapy. And what is that? We give a combination of anti-thymocyte globulin, cyclosporin, and also L-thrombobac. This L-thrombobac is basically a thrombopoietin receptor agonist, and they said that it is a bone marrow stimulating agent. So these are the treatment, the immunosuppressive that we give for patients of aplastic anemia. If this stem cell transplantation is not feasible, obviously we advise in the young to go for this because it is curable. However, if it is that not feasible, you go for this immunosuppressive therapy, and that is the anti-thymocyte globulin, cyclosporin, and L-thrombobac. This is nothing but is a thrombopoietin receptor agonist, means it increases thrombopoiesis, and also it is also a bone marrow stimulating agent. So they say here that adults above 50 years or those without an HLA matched donors, the treatment of choice is the immunosuppressive therapy. Okay? If suppose that even in the young, if they don't have an HLA matched donor, they can go with this immunosuppressive therapy that consists of ATG plus cyclosporin. And the regimen is that there are two types of this ATG. One is the equine one and one is the rabbit one. The equine one is a ATG. We give 40 mg per kg per day IV for 4 days in combination with cyclosporin 6 mg kg orally twice a day. And however, they said that rabbit ATG is more immunosuppressive than equine, so you can give the dose of 3.5, but either whichever is available. And another important thing to be concerned is that this anti-thymocyte globulin should always, because we have such much of transfusion reaction, so it has to be given in combination with steroids at least for 1 week, followed up and taper over the next 2 weeks. So when we started this ATG, we have to combine it with oral steroids in order to avoid the infusion reaction and serum sickness. So are you clear with this? Aplastic anemia? So let me recap again before we go to the other topic which will be discussed in the next class. So what is aplastic anemia? So basically aplastic anemia is a condition of bone marrow failure that arises from injury or abnormal expression of the hematopoietic stem cell. So the bone marrow here becomes hypoplastic and the pancytopenia develop. Classification can be constitutional or acquired. Constitutional, these three: Fanconi's, this keratosis congenita, Schwartzman-Diamond syndrome. Then acquired, we have the causes unknown. Then as a result of chemotherapy, radiation, chemicals and toxins, certain drugs, infections, immune mediated, and obviously very rare pregnancy. So what is the laboratory finding? You'll find pancytopenia picture and the reticulocyte count will be low. Then the bone marrow aspirate in biopsy shows it is a hypocellular marrow. There will be no infiltrations or fibrosis, and the symptoms and the sign they'll present you with the features of pancytopenia. If there are the symptoms of anemia, then leukopenia causes vulnerability to bacterial, to any infection, be it a bacterial or fungal infection. Then thrombocytopenia results in bleeding, and physical examination will reveal the sign of pallor, purpur and petechiae. So this is very important to note that the presence of hepatosplenomegaly or limb adenopathy or bony tenderness in the setting of pancytopenia should question the diagnosis of aplastic anemia. So under the treatment we have supportive and definitive, or others we could say. Supportive like blood transfusion, platelet transfusion, hematopoietic growth factor and treatment of the infection. In the young with a HLA matched donor, preferably hematopoietic stem cell transplantation, but in the people who are aged above 50 years or those without an HLA match, we can give this IST, that is immunosuppressive therapy, that is anti-thymocyte globulin plus cyclosporine. And also nowadays, why we put this? Because this obviously, it is, I can't say to put under IST, it is under the supportive, but we always, when we give these two, we always have to give this L-thrombopac, okay? This is nothing but it is a thrombopoietin receptor agonist. It increases thrombopoiesis and also causes bone marrow stimulating agent, okay? And the ATG, remember that the regimen, the two types, it can be the equine or the rapid one. The doses are different, combined with oral tablet cyclosporin. And when you give ATG, you have to start in combination with steroids in order to avoid the infusion reaction and serum sickness. Okay? So I think today is the end for this class. Next class we'll be talking on a bit on leukemia. So are you clear? I want you to remember this classification because of pancytopenia, because from this I'll be teaching the causes. Okay? See, like I've started bone marrow, hypocellular and cellular, aplastic anemia of touch. So, hypocellular MDS and leukemic, this I'll talk later. I'll be talking on leukemia and MDS. Among these, aplastic, then leukemia and MDS. PNH I've already spoke, then lymphoma will come. Okay? So anyway, thank you so much. You go through these slides because again on the next class, we'll be again coming back to this classification whenever we talk about the disease. So long question on pancytopenia as well as aplastic anemia. They might ask you, what are the causes of pancytopenia and how will you, what are the clinical features and the management of aplastic anemia? It will come like that. It might come, what are the causes of pancytopenia, the causes of pancytopenia, and they'll ask you regarding the aplastic, the management, the clinical features and the management of aplastic anemia. Okay? Thank you so much.